Hello and welcome to the next section of the Falcon Reviews course. We will be going over the pathology of lymphoid tissue, lymph nodes, spleen, and thymus for step 1. So our objectives for this portion of the lecture are to discuss lymph nodes, what a normal lymph node looks like, to go over some situations where you may have some benign lymphadenopathy, as well as to discuss lymphoid neoplasms and what they may look like. From there, we'll have a discussion of the spleen and the thymus, and that will conclude our discussion of the entire lymphoid system for what you'll need to know for the USMLE Step 1. So, discussion of the normal lymph node and lymph node architecture. Starting at the periphery, you have the subcapsular sinus just under the capsule of the lymph node, and you have the cortex and germinal centers right underneath there, and as the name implies, that is an area of significant maturation of the lymphoid tissue. Around the cortex you have the paracortex, and deep within the architecture of a normal lymph node you have the medulla. All of these areas are involved at various points along the process of maturation of the B and T lymphocytes. To discuss benign lymphadenopathy, it is important to discuss what is lymphadenopathy. It is an inflammation of a lymph node characterized by cortical or paracortical hyperplasia, which is often caused as a reaction to acute infections, sometimes bacterial, sometimes viral. The most frequent presentation is tender, enlarged cervical lymph node in the setting of suppurative or bacterial pharyngitis. Chronic nonspecific lymphadenitis can be manifest as long-standing non-tender lymphadenopathy and is a little bit more concerning than acute lymphadenitis from known infection. Some etiologies of chronic lymphadenitis include autoimmune disease, infection with HIV, other chronic infections, or an effect from some medications that we use. We discussed lymphoid neoplasms, ALL and CLL, in a prior lecture, but it's worth going over the lymphomas. We're going to start with a discussion of non-Hodgkin's lymphomas, the follicular lymphomas, diffuse large B-cell lymphoma, and Burkitt's lymphoma, and then a discussion of Hodgkin's lymphoma and plasma cell disorders. In general, non-Hodgkin's lymphomas are of B-cell origin. There are some T-cell neoplasms that are non-Hodgkin's lymphomas, but you're probably not going to be tested on them on the USMLE Step 1 exam, so we won't cover them at this point. Non-Hodgkin's lymphomas usually present with widespread lymphadenopathy and marked B symptoms. By B symptoms, we mean fever, weight loss, and night sweats. And those are important for both staging and prognosis. They change people from a stage A to a stage B, depending upon the number of the stage 1, 2, or 3. Non-Hodgkin's lymphomas can spread non-contiguously and often involve extranodal sites. So when you think of a non-Hodgkin's lymphoma, think of it sort of as a diffuse process at presentation. Non-Hodgkin's lymphomas are important to determine what cells are involved. So we use things like CD markers. So CD stands for clusters of differentiation. And the numbers are going into the hundreds as we discover more subtypes of the subtypes of the various types of white blood cells. The cell surface markers are used in flow cytometry and immunohistochemical analysis to subtype what kinds of lymphomas and leukemias we're dealing with in any particular patient. For the purposes of Step 1, it's probably worthwhile to know some basics. CD19 and 20 are B-cell markers, and CD3 and 5 are T-cell markers. You can think of some of these CD markers sort of like they're an identifiable marker seen from afar. It's sort of like a jersey on an athlete in a sport. You can't necessarily see precisely what they're doing from afar, but you know what number they are, and that helps you determine what their function is. So a discussion of other specific lymphomas, follicular lymphoma carries oftentimes a translocation 14-18. This juxtaposes the BCL2 gene with the constitutively active immunoglobulin heavy chain gene, which causes unregulated expression of BCL2, which is a negative regulator of apoptosis or programmed cell death. So this causes increased survival of the cells in the germinal center, which can cause hyperproliferation and no apoptosis, leading to disordered cell cycle production and leading to lymphoma. So it's called follicular lymphoma because it completely replaces the normal architecture of the lymph nodes with subcapsular sinus, cortex, paracortex, and medulla, with enlarged follicles consisting of small cleaved lymphocytes. So you can see a gross and microscopic specimens of follicular lymphoma, so a low power and a high power view. Follicular lymphoma is the most common of the non-Hodgkin's lymphomas, usually presenting in middle age. It is fairly indolent. The average survival is about 8 to 10 years. But what's difficult about follicular lymphoma is since it is not as quickly growing as some of its other lymphoma colleagues, it is not particularly amenable to conventional chemotherapy. 30 to 50% of follicular lymphomas can transform to the more aggressive large B-cell lymphoma, which, though more amenable to some types of chemotherapy, oftentimes grows very rapidly and can outstrip even our best in terms of therapy. Diffuse large B-cell lymphomas, those that are transformed follicular lymphomas, that 30% do carry the translocation 1418. Another 30% carry translocations involving BCL6, a gene that is involved in the regulation of the maturation and differentiation of normal B cells. Diffuse large B-cell lymphoma is a common finding in immunodeficient states as a result of transformation of lymphocytes due to Epstein-Barr virus, which normally causes mononucleosis, or HHV8, which can be associated with Kaposi's sarcoma. Diffuse large B-cell lymphoma causes diffuse replacement of the lymph node parenchyma with large pleomorphic cells. So it is, as it is described, a diffuse large B-cell lymphoma. It is more common in older patients, but does have a wide range of ages, including children to adolescents, up to even folks in the early elderly age. Patients usually do present with a rapidly enlarging mass, either at a lymph node site or at some extranodal site, causing extrinsic compression of associated structures. So symptoms, if they're present, are usually due to tissue destruction or mass effect. Diffuse large B-cell lymphoma is very aggressive, but can respond to chemotherapy, causing a lasting remission in up to 50% of the patients. Another very aggressive lymphoma is Burkitt's lymphoma. There are a variety of subtypes of Burkitt's lymphoma, either endemic or sporadic, and these are primarily associated with latent Epstein-Barr virus infections. Many of these carry translocations involving the c-MYC gene on chromosome 8. The most common translocation in Burkitt's lymphoma, and that which you could be tested on, is the 814 translocation juxtaposing c-MYC with the immunoglobulin heavy chain gene. These translocations lead to the unregulated expression of c-MYC that positively regulates cell growth and division. So it's sort of a gas pedal, reminding everyone to continue to divide. So Burkitt's lymphoma, from a morphologic standpoint, has medium-sized cells that are just packed into the lymphoid tissue when biopsied. There are large numbers of mitotic, large numbers of dividing and dying cells. So the cell turnover is very, very rapid. This is a tumor that can go from nothing to a profoundly space-occupying lesion on the face of a child in the endemic area, which you'll see in just a couple of slides. Again, from a pathologic standpoint, the classic thing to remember is that there are scattered benign macrophages in this sea of blue mitotic and apoptotic cells, which gives it that characteristic starry sky appearance. Here's a picture of a rapidly expanding mass in Burkitt's lymphoma. These can progress over days to weeks in the endemic area. All of the pathology of Burkitt's lymphoma can occur at extranodal sites, so it's not isolated to lymphoid tissue. Quite the contrary, it is often well outside of the lymphoid system. So the three types of Burkitt's lymphoma, the African subtype, which is seen in the mandible of young kids, and that is the lymphoma that was initially described by Dr. Burkitt. The sporadic Burkitt's lymphoma can present as an abdominal mass, which again has manifestations as a space-occupying lesion causing abdominal pain and early satiety as well as a decreased appetite. The HIV-associated Burkitt's lymphoma is very rapidly progressive and very, very aggressive, seen in the setting of HIV infection, and oftentimes can be partially treated with initiation of highly active antiretroviral therapy. However, treatment of the lymphoma itself is always required. So the endemic and sporadic forms are seen in children and young adults. The HIV-associated form can occur at any age as long as the patient does in fact have HIV. These lymphomas are very, very aggressive and can become devastating if not treated very quickly, but it does respond well to short-term and high-dose chemotherapy. So we'll step back and do a step 1 simulator question. This is a 53-year-old male with an enlarged supraclavicular lymph node. No hepatosplenomegaly is present. The biopsy shows the lymph node's normal architecture replaced by large lymphoid cells, enlarged nuclei, prominent nucleoli, with immunohistochemical staining CD19 and CD10 positive, CD3, CD5 negative. So the most likely diagnosis, we'll walk through each of the selections and kind of go through. Reactive lymphadenitis is probably not going to be the case because a 53-year-old person probably isn't going to have much in the way of reactive lymphadenopathy to a bacterial infection. Reactive lymphadenitis is more commonly seen in kids. Furthermore, any lymph node in the supraclavicular fossa is almost always a malignant process, either a metastatic process or some primary malignancy. So always merits further investigation in the supraclavicular fossa. So we've ruled out reactive lymphadenitis. Is it diffuse large B-cell lymphoma? Well, it has the normal architecture replaced by large lymphoid cells. So it is diffuse, the cells are large, and they are staining in an immunohistochemical pattern consistent with B cells. So it could be reasonably argued that this is diffuse large B-cell lymphoma. Is it a T-cell lymphoma? We've already talked about the T-cell markers, CD3 and CD5 are negative, and it would be very rare for this patient to have a T-cell lymphoma. Multiple myeloma, in this situation, probably not going to be the case because the biopsy would reveal sheets of plasma cells rather than the large lymphoid cells that we see. And a Burkitt's lymphoma, probably not going to be the case because Burkitt's is often going to present as extranodal manifestations of disease and not necessarily in an isolated supraclavicular lymph node. Which of the following disorders is most likely associated with translocation 814? Well, we talked about chronic myelogenous leukemia in a prior lecture having a translocation involved, but that's more of the 922 translocation. Acute lymphoblastic leukemia, probably not going to have that specific translocation present. Is it going to be diffuse large B-cell lymphoma? We talked about the translocation that takes place there, that's the 1418. And acute myelogenous leukemia, the M3 subtype, probably not going to be the case. So let's look back and see if Burkitt's lymphoma is going to give us translocation 814. It sure does. So this is most likely going to be a Burkitt's lymphoma. So we'll move on from non-Hodgkin's lymphoma to Hodgkin's lymphomas. So it's worth going over to contrast with non-Hodgkin's lymphomas. Hodgkin's lymphoma typically presents in a single lymph node or in a patch of several adjacent lymph nodes and is confined only to the lymph nodes with little extranodal involvement. It spreads in a contiguous fashion from one node to another and consists of a few neoplastic cells followed and surrounded by many benign reactive cells. The Reed-Sternberg cells are the neoplastic cells that we need to concern ourselves with. So the pathogenesis of Hodgkin's lymphoma is not very well fleshed out. There is evidence of EBV infection in the Reed-Sternberg cells, and there are other cytogenetic abnormalities that are predisposing to Hodgkin's lymphoma. The surrounding cells around these Reed-Sternberg cells result from the expression of cytokines, specifically TNF and some of the interleukins, that are produced by the Reed-Sternberg cells. So what does a Reed-Sternberg cell look like? So the furthest to the left is the classic Reed-Sternberg cell with the bilobed owl-eye nucleus. There's the lacunar variant, which is second from the right. The mononuclear variant, which is larger and appears to look like a monocyte. The popcorn variant, some of the sort of smaller and interspersed cells are what appear to be more consistent with Hodgkin's lymphoma. The different subtypes of Hodgkin's lymphoma are also worth going over to see which cells are involved and what the pathology looks like. A very common presentation is that of the nodular sclerosis type. It is they are either the classic Reed-Sternberg cells or the lacunar type. And the background cells have bands of fibrosis with other mixed cellularity. These are common in young adults, and the incidence between males and females is relatively equal. Mixed cellularity often has a mononuclear look to it, or with a classic Reed-Sternberg cell with a mixed background of cells. It is an uncommon type, with males being affected more predominantly than females, and is often more aggressive and more advanced stage at presentation. The lymphocyte-rich is much more uncommon. The background cells are T lymphocytes, and the cells themselves appear to be more in the mononuclear or classic Reed-Sternberg type. Lymphocyte depleted are often seen in older patients with HIV. And the nodular lymphocyte predominant are the ones with the popcorn type cells, and it's also very uncommon to see, but they are also male predominant and more readily seen in our young population. The tumor staging of Hodgkin's lymphoma is very similar to any other staging, where stage 1 is exclusively local disease, stage 2 can be more locally advanced disease, stage 3 has 2 or more lymph node groups involved on both sides of the diaphragm. And stage 4 extends from beyond the base tissue, so outside of the lymphoid tissue, to other regions, including lung, liver, and other areas. Hodgkin's lymphoma can often present as enlarging lymphadenopathy with or without B symptoms. And the prognosis is dependent on the stage, but is generally quite good, with stage 4 disease having 5-year survivals in the 70% range. The CD markers, so they often have CD15 positive, CD30 positive, and CD45 negative. And that's in every form except for the lymphocyte predominant form, which is the exact opposite. CD45 positive, CD15 and 30 negative. A question about Hodgkin's lymphoma. 33-year-old woman presents with fatigue and night sweats for several months. Physical exam is remarkable for right cervical lymphadenopathy. The biopsy is performed of one lymph node showing thick bands of fibrosis, with intervening lymphocytes and other cells. Classic Reed-Sternberg cells are seen. The abdominal CT and bone marrow are read as normal. The subtype and stage of her Hodgkin's disease is. Well, you can look at this, and if you see a solitary lymph node and the abdominal CT and bone marrow are normal, that eliminates B, C, and D from the diagnosis, because you know this is stage 1 disease. So the question is this lymphocyte predominant or is this nodular sclerosing? So you look at the biopsy results and you see thick bands of fibrosis with various types of cells, lymphocytes, EOs, plasma cells, and you can say that this is nodular sclerosing Hodgkin's disease, stage 1. So that concludes our discussion of non-Hodgkin's and Hodgkin's lymphomas. We will discuss other lymphoid malignancies and other diseases of the spleen and thymus in another section.